Hello everyone, I'm Ankita Tiwari. I'm happy to welcome you all on behalf of International Pediatric Association. Before moving ahead, I would like to quickly go through a few instructions for the attendees. As you all know that today's webinar is available in English, French and Spanish languages. You can switch the language with the help of interpretation option present at the bottom of your screen. You can also mute original audio while using interpretation feature for good sound quality. For the Q&A session, please post your questions in the Q&A box. Questions posted in the chat box will not be considered. Also, please note that at the end of the webinar, we will share a post-webinar survey form link in the chat box. We request all of you to please spare a few minutes to fill the form. Now, moving ahead, I would like to invite Professor Enver Hassanoglu, President of International Pediatric Association, to give his opening remarks. Thank you. Over to you, Professor Hassanoglu.
Thank you. Dear colleagues and friends, good evening, good night, good morning, and good day, and salute from Ankara, Turkey. I'm Professor Enver Hassanoglu, President of IP. I am happy to be with you, and in fact, you are, the speakers and the moderators are going to talk about COVID-19 and routine vaccination in children in details in this period. As you know, we are facing a rough and difficult storm of COVID-19 since 2020, and many lives has been lost during this pandemic, and our children affected as well. They lost their lives, they lost their schools, and due to restrictions and lockdowns, they suffered mentally, physically, and psychologically. And what do we know about the new variant of COVID-19, Omicron, that it is spreading so fast, but it is milder in our children. Even though so many countries began to close their schools again and started to do booster shot to the people and the children. But the most important thing is there is no equity in vaccination, and so many people, especially in Africa, had not been vaccinated at all. We should think about this position and how we can improve this and deal with this problem and stop the pandemic in this condition. And another important issue that the pediatricians and healthcare workers and parents neglected the routine immunization of children as well. And I'm afraid of this because it will lead to another infectious pandemic like measles, meningococcal, pneumococcal, etc. And I'm sure you are going to focus on this condition as well. At end of my speech, I want to thank all attendees and all speakers and all moderators, and of course, our sponsor, Sanofi Pasteur, as well. Thank you and good luck.
Thank you, Anwar. Hello, I am Dr. Naveen Tucker, President-elect of International Pediatric Association, and it's my pleasure to introduce Dr. Walter A. Orenstein, who is a professor of medicine, epidemiology, global health, and pediatrics at Emory University, as well as Associate Director of Emory Vaccine Center and Director, Emory Vaccine Policy and Development. Everyone knows Walter very well, and he is popularly known as Mr. Immunization for USA. And we all know their famous book, Stanley Plotkin, Walter Orenstein book on vaccine. Walter, over to you.
Thank you very much, Naveen. It's a pleasure, and thank you all for participating in this webinar. When we think about COVID-19, the focus has primarily been on adults, but as we all know, it has had a substantial adverse impact on children, both directly from illness and complications of illness, as well as indirectly, such as no school and other things. Our goal today is to talk about what we know about the COVID-19 burden in the world, what we know about its adverse impact on routine immunization and how we potentially overcome it, and what we know about the available vaccines and what their record is in terms of use, their effectiveness, and their safety in child populations. We have a very distinguished set of speakers and a super panel of people around the world who can give us ideas. And with that, I'd like to turn it over to Miguel Orion from Chile, who has played a major role in this and moderated a very similar session at the International Society for Infectious Diseases. Miguel.
Thank you, Walter. Hello, everyone. It's truly a pleasure to be in this impressive webinar. As Walt said, we have a very distinguished group of speakers and panelists who will be giving an overview, I think, of what is happening with COVID-19 vaccination in pediatric populations and also the influence on other vaccines. So we want to be very keen on time. We will have this will be structured in sort of three main components. We will have two talks of 15 minutes each. Then our panelists will give six panelists will give each during 5 minutes an overview of what's going on with pediatric vaccination in their countries and regions. And then we will end up with hopefully 20 minutes of discussions and looking at your questions and answers. So with that, I want to give a very warm welcome to Zulfi Bhutta. Everybody knows Zulfi. He's the founding director, Center of Excellence in Women and Child Health at the Aga Khan University in Pakistan. He's the chair in Global Child Health and co-director at the Sick Kids Center for Global Health in Toronto. And just to mention, and that summarizes what Zulfi is, he's adjunct professor to Johns Hopkins, Harvard, Tufts, University of Alberta, London School of Hygiene and Tropical Medicine. So you can have an idea of who will give us the talk on burden of COVID-19 in children and impact of COVID-19 pandemic on routine child immunization. Zulfi, the floor is yours.
Thank you very much, Miguel, for that kind introduction. I think the claim to fame that I have is that I am the global ambassador for IPA since I stepped down as its president a few years ago, and it's my great privilege to be working with Anwar and Naveen Tucker in this area. I know we have limited time, and what I will share with you over the next few minutes is principally the following areas. I'll talk a little bit about the burden and the spectrum of pediatric COVID-19 worldwide, a little bit about multi-inflammatory syndrome. I will cover indirect effects of COVID because they are really important and germane to our discussions today. I'll cover schools and transmission risks in order to make the case for childhood immunizations with COVID-19 that my distinguished colleague Evan will follow up on. So ladies and gentlemen, it's amazing as we look at the global burden of COVID-19 today that we have exceeded 270 million cases worldwide. Just United States has exceeded 800,000 deaths due to COVID-19. And globally, we are over 5 million officially confirmed deaths due to this disorder, with no country of the world spared. In fact, there is evidence, if you look at the Institute for Health Metrics and Evaluation, that some of the overall mortality associated with COVID-19 could be several folds greater. And this map represents perhaps the discrepancy between officially reported deaths due to COVID-19 and what could be deaths that are principally not reported within their own health information systems. And you just have to see Africa and Asia standing out as they are. The work that I'm going to share with you today was undertaken by a COVID-19 working group that I established last year earlier on, and this represents a number of scholars working across various continents and working on various aspects of COVID-19 in children. And I'm very grateful to their support, and I'm very grateful to the IPA for being a major partner in this endeavor, as well as other agencies like UNICEF. Let's look at the direct effects of COVID-19. If you look at the global data from what we know, and these are compiled by the World Health Organization last month, children represent, both in terms of cases and mortality, a very small proportion of global deaths. And in terms of their distribution between under 5, 5 to 10, and adolescents, the number of deaths overall represent less than 1% of the overall mortality due to COVID-19. Much of it is clustered also in adolescents. So if you go down below adolescents, both as a proportion of global cases and as a proportion of deaths, the overall figure appears to be much smaller. But these are global aggregate figures from case fatality rates and what we have. And there is emerging evidence now that this may not be uniform across the world. So the big question as to what is the true spectrum of COVID-19 morbidity and mortality in children worldwide has been answered through a series of systematic reviews and publications that we put out over the last year and a half. And I'll try and summarize those data very succinctly. So till a few months ago, before our update, we had about 129 case series of children with proven COVID-19 infections worldwide, and these represent almost all the geographies. But you will notice that we have very little information from Africa. There have been very few publications outside of South Africa of COVID-19 infections in children, not because it doesn't exist, because diagnostic limitations and publications have been few and far between. Most of these cases appear to be mild. I will talk about multi-inflammatory syndrome, but if we look at general COVID-19, excluding mix, most of the symptomatology and features are mild, comparable to upper respiratory infections, with fever being a dominant feature in about 70% of the population. As I've already shown, if you look at from these 67 pediatric case series where we have age distribution, the burden appears to be greater amongst children beyond 10 years of age, and is a gradient. Much of the younger age groups are perinatal or newborn transmission of COVID-19 from the mother. This is an important slide which tells you what may be the differences between high and low middle income countries in terms of quality of care and outcomes. So this is the aggregate data which says it all. If you look at case fatality rates or death rates, about twofold higher amongst children in low and middle income countries. And you can see one of the differences that may underlie this is access to intensive care and access to supportive care like mechanical ventilation. The same is evident in the subgroup that relates to multi-inflammatory syndrome. We published a review on this very early on last year, and this has been updated recently and represents close to around 90 case series on multi-inflammatory syndrome, representing, again, similar geographies, but relatively fewer reports from low and middle income countries. But what we have confirms also what I told you for general COVID-19 infections, that we have a significant difference in adverse outcomes, case fatality rates amongst those who are admitted with multi-inflammatory syndrome in low and middle income countries, about fourfold difference. And the difference may be related to differences in receipt of intensive care. Very recently, just last week, some data were shared from a multi-center study in Pakistan where case fatality rates in the subgroup as high as 20% were reported. So there are differences that one needs to recognize in terms of COVID-19 in children. And if I was to summarize the global evidence, I would say it's an infrequent disease in children, symptomatic disease, but with a gradient that has a higher proportion of cases in adolescents. Those who have comorbidities typically tend to have adverse outcomes. So if you look at where the deaths are located amongst children who have died with COVID-19, they are generally those who have associated complications. But high rates of adverse outcomes in low and middle income countries are potentially related to differences in health system and support. The good news in here is that despite a significant increase in COVID-19 due to the Delta wave, there hasn't been an upsurge in relative proportions and complications of severity of disease. Now, very early on in the pandemic, in fact, as early as March last year, UNICEF had put out a report on COVID-19 in children, which is a very important report. And I just verbatim quote from the beginning of that report. It was said that children may not be the face of the pandemic, but they risk being among its biggest victims as their lives are being changed by COVID-19 in profound ways. And this was very early days and a very prescient observation. And that has indeed been the case worldwide, that the measures that we put in place to mitigate the disorder, certainly such as lockdowns, closure of schools, businesses, offices, increase in poverty, that has had an impact on children that may be much more harmful than the actual disease itself, which appears to be mild in children in general. What is the evidence for my saying this? Well, we have looked at this in great detail in the region that I personally come from, which is South Asia. This was a report that we put out a few months ago with UNICEF and ROSA, and it has also been updated since, looking at just South Asia, the cluster of 6 countries that we focused on in that region. So if you look at that region, it has had its own fair share of waves of confirmed COVID-19 cases at a population level, and no country's been spared. Even look at Sri Lanka, which has such a fantastic primary care, had its own upsurge of COVID-19 cases in general, also associated with a relative increase in mortality related to population distribution. So the region has seen cases, the region has seen mortality, and the region also responded to this. So this is a graph which is a composition of the stringency index, a composite measure of school closures, lockdowns, workplace closures, travel bans. And as you can see across this region, like anywhere else in the world, very early on in the pandemic, there was a massive immediate response right after WHO declared it a global pandemic, and almost everything shut down and remained the case for a while. But look at what's happened since. Even in this cluster of 6 countries representing the same region, tremendous diversity in how people opened, reopened, closed, reclosed, and nothing's been more important in this than school closures. So if you go from March last year to now, and I'm just going to show you graphically what's happened to school closures, virtually everything closed by May. And since then, there has been a big up and down in terms of some schools opening, some schools closing. In October, it appeared that things were going to open immediately, and I now fear that with Omicron, this is going to be also delayed. So this is the picture as of December 2021, that we still have many geographies where schools have not opened completely for children. Now, what could be the impact of this? Now, I don't have a lot of time to go through everything. We are going to talk about reduction in health services and immunizations overall because of these stringency measures. But I'm going to speak a little bit about the disruption of education, because today's focus is on children, and particularly the importance of the disorder in school-age children. Now, we've looked at actual official data from district health information systems of what's happened to coverage of essential interventions. And this graphic captures almost a year and a half of data from actual DHIS across these 6 countries in South Asia. And the take-home message is that almost everything went south. Just look at what's happened with immunizations also. By the middle of last year, there's been tremendous disruption, about 30–40% reduction in immunizations. And although things have built up, you will notice that with the recent upsurge, we've still not reached normalcy. So a lot of services for children, both in terms of care, seeking care, provision, nutrition services, have been disrupted really big time. And the impact that we estimate on child mortality in the region has been quite significant. about 10 to 12% excess mortality, both for children and mothers. And these numbers are quite massive when you put them together. The impact on education is massive. 400 million children who are school age in South Asia have been out of school since March, and many of them are permanently out of school. And some of them cannot be reached by remote learning or distance learning. And this loss in educational attainment, because of children not being able to go to school, may be semi-permanent in terms of many critical ages on which the impact can be irreversible if you lose that window of opportunity for learning at critical period. And these numbers, as you can see, in terms of mean years of education lost, have been estimated to around 7 years. So this is not trivial, ladies and gentlemen. And for pediatricians, it's extremely important, because this is really where we come in as advocates for children and adolescents worldwide. For adolescents, this is my summary slide. Of the 4.5 million girls that have been estimated to drop out of school in the region, many will be married off. And this early marriage in girls who've been out of school will have its own consequences in terms of adolescent pregnancies and adverse outcomes in relation to not only morbidity and mortality, but also impact on child development and growth. And these numbers tell you that these are not trivial. So what is the evidence that schools ought to have closed, or schools represented a major cluster of problems in COVID-19 for the rest of society? So we've recently published a systematic review, which still remains the largest review in this area, looking at close to around 90 major reports and studies. And I'm going to summarize them in 3 slides. So firstly, adolescents have the same risk of infections as adults, but children less than 10 years of age have a significantly lower risk of infection with COVID-19 from data available from school platforms. The risk is even lower in daycare settings. If you take preschool and daycare settings, I mean, the risks are lower than even primary schools. And you will see this gradient going up as children become older. But by and large, the risks are no greater than that of adults. The important thing to remember is that keeping schools open had no impact on overall disease burden in communities. It was thought that if you have children in school and they catch infection, there'll be a risk to the rest of the family members and communities. The evidence on that is totally opposite. That if schools are open or closed, it doesn't matter. As you can see, during school closures or whether schools remained open, actually the evidence supported schools remaining open during the course of infection. And many countries in the world, developed countries in the world, have actually done so during the course of the illness. But let me now, as I wind down towards the latter end of this, say a few words about the implications of all of this for childhood immunization policies, which has been a source of great divided opinion. And that relates to the link that people are making between vaccinating children and vaccinating adults. So it is important to remember that this is an unequal world, and that vaccinations are at this point in time the greatest source of divide between high and low middle income countries. If you look at this map, which is a fairly recent map, and look at COVID vaccine administration, of the 8.5 billion doses of COVID-19 vaccine that have been administered to almost half the world's population, many low-income countries have received virtually nothing. Only 7.1% of the population in low-income countries have received 1 dose. And look at what Africa stands out like. And COVAX, despite its best efforts, has only shipped out 600 million doses to 144 countries, representing a very small proportion. And you can see this data very clearly in this total doses administered per 100 population. Look at the difference between upper and middle-income countries, high-income countries, even LMI, lower middle-income countries, and low-income countries. So this gap, this divide, is not only a source of emergence of variants, is also increasingly, to my dismay, the reason for this denial of vaccination to children. So are children being vaccinated and are considered eligible for COVID-19 vaccination? You will see very clearly that there is a north-south divide. If you look at the low and middle income countries, particularly countries in Africa, where we are talking about, and countries in Southeast Asia, it is only partially available to some children, mainly adolescents at the moment. And the jury is out in terms of what needs to be done. So what considerations, what does one need to have in terms of childhood vaccinations for COVID-19 and LMICs? Firstly, we have to recognize that given COVID-19 protocols currently in place, mitigation strategies such as just promotion of hand washing and masking may not be enough. And this interruption in learning because of exposures, particularly its gender dimensions and the stringency measures that I've talked about, are actually having an impact on children that is not being measured worldwide right now in any of the indicators. The mental health effect of keeping a whole generation out of schools, not only in terms of its consequences of learning, but in consequences of long-term deficits, is massive. These indirect effects of COVID-19 on children, on education, mental emotional health may be much more important in the long term than direct effects. And there are additional considerations that suggest that we need these additional measures because all of the other measures that I've talked about, such as staggering schools, hand washing promotion, use of masks, may not be adequate in these settings alone in terms. Yet the World Health Organization has taken a principled stance on principled vaccine availability to say that until all or a large proportion of adults are vaccinated, children should not be vaccinated. I don't think that's the right approach. As we look at what has happened with many of these upsurges and waves, these are data from the US, from what happened in the US with the Delta upsurge, you will see in the latter part between late summer and until recently, much of the increase in cases that we saw was in school-age population because they were unprotected, whereas adults were protected. So you are going to get cases in children if you do not vaccinate them, and many of them will have interruption in their learning and schooling. I'm not going to talk about Omicron, which is a big global challenge, but it is highly infectious, may not be associated with significant morbidity, but it is the new pandemic which is now going to affect children worldwide and adult populations, and therefore vaccination assumes an even greater importance given the transmission and transmissibility of this virus. So let me close, chairs, ladies and gentlemen, by my summation based on my reading of the literature and our work on what has been the impact of COVID-19. I'm convinced that the indirect effects of COVID-19 on the lives of children and adolescents are far worse than any direct effect estimates. I don't believe that there is any reliable data to suggest that there is an excess risk in children if schools were to remain open. And all of the data that I've shared with you from the systematic reviews shows that that risk may be exaggerated, and children, in fact, should be going to school because it doesn't really impact overall epidemiology of the disorder. We need studies on the effectiveness of mitigation measures in educational settings, but I think they need to include vaccinations because it's not a question of either or. In my opinion, the vaccinations of school-age children and maybe even younger children are important to fully protect these children and give them some of their life back. Imagine for the last 2 years, and think about this as your own children. If children have not had birthdays, if they've not had social functions and interaction with their peers, or sporting events, which are such an important part of learning and growing up, what kind of a childhood have we been giving our children, not just for a few months, but for close to 2 years now? And I don't think as pediatricians, we should stand to that interruption in child development and should ensure, therefore, that through our advocacy, vaccines are also made available to children across the board, particularly in low and middle income countries where the consequences of all those interruptions may be much greater. Thank you very much for your attention. And back to you, Miguel.
Thank you very much, Zulfi. I think that was a superlative talk and very helpful. Our panelists. Our next speaker is Evan Anderson. Unfortunately, he was not able to participate live, but he did do a recording. Evan will focus his talk on safety, immunogenicity, and efficacy of COVID-19 vaccines in children. Evan is co-director of the Emory Vaccine and Treatment Evaluation Unit and the director of the Emory Children's Center Vaccine Research Clinic. His major research has involved rotavirus and studying impact on adults, but he also has led major national COVID-19 vaccine trials at both the adult and pediatric levels. And he is really superb in talking about and has a tremendous knowledge of the safety, immunogenicity, and efficacy of COVID-19 vaccines in children.
Hello, I'm Dr. Evan Anderson. I'll be speaking about the safety, immunogenicity, and efficacy of COVID-19 vaccines in children. I have potential conflicts of interest, most notably serving as the PI locally for the Pfizer and the Moderna COVID-19 pediatric studies, and I do have children. The objectives will be to discuss the safety of COVID-19 vaccines and to outline the data for the immunogenicity and efficacy of COVID-19 vaccines in children. Starting with a quick background, as you can see, there are multiple potential strategies for a COVID-19 vaccine. Some of these are well-known and established techniques, such as live attenuated, inactivated vaccines, vectored vaccines, recombinant protein vaccines. Of course, we've seen the mRNA vaccines move most quickly into clinical practice, but there are a number of different vaccines that are being used worldwide. In terms of vaccine development, critical factor is that you need immunogenicity in order for a vaccine to move forward. Importantly, we also assess safety and reactogenicity. There is overlap between safety and reactogenicity, but reactogenicity can impact the safety, for example, febrile seizures in association with certain vaccines, but that reactogenicity is overlap is only partial. The general philosophical approach has been to minimize reactogenicity. However, safe vaccines can have substantial reactogenicity and also better immune response. For example, would be the Shingrix vaccine versus the Zostavax vaccine in adults. There were a number of concerns as clinical trials were initially beginning about the potential of having deleterious responses to a COVID-19 vaccine. For example, a swine flu vaccine and GBS in the 1970s highlight the fact that rare unintended consequences are possible with any vaccine. With dengue, we have seen antibody-dependent enhancement of disease occur, and with the RSV vaccine formulation in the 1960s that was formalin inactivated, there was vaccine-associated enhanced respiratory disease. And this was thought to be both antibody and T-cell mediated phenomenon. And really this highlights in part the importance of carefully assessing safety to avoid similar problems in the future. From a safety standpoint, we have actually substantial data about the safety of current vaccines. Importantly, data that have looked at the US FDA have looked at post-marketing safety, and in essence, over the course of time, over about a 20-year time period, almost 30-year time period, the US has approved 57 vaccines, of which only one has had a safety-related withdrawal, and that was the RotaShield vaccine. There are multiple systems that perform safety surveillance in the US, some of which are passive and others of which are active. What has been seen is that there's an incidence with the mRNA vaccines of myocarditis, particularly in the week after receipt of vaccine, although perhaps even as far out as 21 days. Passive surveillance systems suggest that, that in essence, outcomes are in general good post myocarditis, with primary symptoms at presentation being chest pain, pressure, and discomfort. Elevated troponin, abnormal EKG findings, and abnormal MRI are common, but the majority do quite well and are discharged home. Importantly, myocarditis can occur with COVID-19 infection among children as well. And here is data to highlight this. So for COVID-19 in and of itself, it's infrequent, but certainly is occasionally diagnosed to have myocarditis in association with COVID-19. It appears that that risk is higher, in particular with the post-COVID inflammatory syndrome called MIS-C, as you can see in both of these cohorts. But I think it is important to note that myocarditis can occur post-COVID infection itself. The best data that we have about the risk come from the vaccine safety data link system, which notes that perhaps the risk is around 37 per million doses administered in the US. I'll give you some perspective about that potential impact on subsequent slides. But in terms of assessing in males 16 to 17 years of age, if for every million doses of vaccine administered, roughly 56,000 cases of COVID-19 would be prevented, 500 hospitalizations, 170 ICU admissions, and 4 deaths, but with some risk of 73 cases of myocarditis. For the Janssen vaccine and also for the AstraZeneca vaccine, there's been an associated rare TTS occurring post-vaccine that does seem to be higher in females. That risk is in the range of 12 per million doses administered. I put together this slide, which highlights understanding of risk and talk you through this over the course of the next minute or so. Many of us fear the risk of a shark attack, which is actually less than 0.1 per million people per year. In comparison, the risk of getting struck by lightning is about 1.6 per million per year. For rotoshield, which was associated with intussusception in the late 90s, that's at about 100 per million doses administered. In the US, a car or influenza death is roughly nearly 200 per million people per year in the US. What has been seen is the risk of intussusception with Rotarix and Rototec, which was initially not identified due to its fairly low incidence of about 1 to 5 per, 10 to 50 per million doses administered. In a very nice editorial at the time that this was identified, Roger Glass and Umesh Parashar essentially noted that the benefit of continuing vaccination far outweighed the potential rare adverse event associated with Rototec and Rotarix, and these vaccines continue to be used. If we then put in some of the common, quote unquote, common side effects from vaccines associated with COVID-19, risk of anaphylaxis is roughly 5 per million, so it's about your 3-year risk of getting struck by lightning. Overall, your myocarditis, pericarditis risk with the mRNA vaccines is about 10-fold higher than your risk of getting struck by lightning. For the adolescents, which appear to be the highest risk group, it's maybe equivalent to the 30-year risk of getting struck by lightning. In comparison, nearly 100-fold higher risk of dying of COVID-19 in the US since the onset of the pandemic. So in summary, the risk of myocarditis, pericarditis is small, but clearly higher in males, adolescents, and young adults in association with the mRNA vaccines. The COVID-19 related risk of myocarditis, pericarditis is actually higher than the risk of vaccination associated myocarditis and pericarditis. The benefit clearly outweighs the risk, and this risk is much lower than the risk of many other quote-unquote routine risks. From a pediatric data standpoint, assessing COVID-19 vaccines, I'll highlight the adolescent data, which demonstrate, in essence, and I've highlighted with red arrows, those that are over 30% as far as reactogenicity. You can see that pain at the injection site is the most frequent local symptom in association with mRNA receipt, here the Pfizer vaccine. With the first dose, you do see fatigue and headache being the most frequent symptoms. And with the second dose, you also see chills and muscle pain also popping up, over 30% of all adolescents that receive vaccine. Importantly, the The GMTs, or the immunogenicity of the vaccine, is very good. It actually appears, although not meant to be a superiority assessment, does appear even a little bit higher than that of those that had received vaccine that were 16 to 25 years of age. You can see very good efficacy. For the Moderna vaccine, again, pain being the most frequent local symptom, and then headache, fatigue, myalgias, and chills also being the most frequent symptoms, with over 30% of those that receive vaccine experiencing these. Similarly, they saw similar immunogenicity to that of the 18 to 25-year-olds that were compared in the Moderna study, and 100% efficacy in against the primary efficacy endpoint of COVID-19 infections beginning 14 days or later after the second dose of vaccine. The FDA here in the US has decided to delay decision on Moderna coronavirus vaccine for adolescents to evaluate a myocarditis risk, according to the company. The data from the US does appear mixed as to whether the risk is higher with Moderna versus Pfizer, as far as rationale for why this delay might happen. And they do note over 1.5 million adolescents have received the vaccine worldwide and do not note increased risk of myocarditis. There's been a lot of questions about when we might have data for those less than 5 years of age with mRNA vaccine. So we have very limited data about that are public about a potential timing for an announcement. It was thought previously in the last timeline that's been provided that the less than 2-year-olds might have data in October, November. Obviously that hasn't happened, but we do know that the dosing is less, so 1/3 of the adult dose in the 5 to 11s and 1/10 of the adult dose in the 6 to 4-year-olds. Moderna's timeline is a little more vague. Both Pfizer and Moderna were asked by the FDA to increase their trial sizes, which is likely contributing to this delay in terms of actually having data about the immunogenicity, safety, and potential efficacy. So in the 5 to 11-year-olds, Pfizer has published their data now, which note that, again, pain at the injection site is the most frequent symptom. And then importantly, you see just fatigue being over 30% of all vaccine recipients, perhaps a little more reactogenicity with the second dose, but in general, it appears better tolerated than it was in the adolescents. Here is their efficacy data and their immunogenicity data, which essentially shows that the antibody titers are very similar to the 16 to 25-year-olds and those that are 5 to 11 at this 10 microgram dose. And you can see that efficacy is very good, so about 90% with the Pfizer vaccine. For the Moderna vaccine, we have just press reports to date regarding the vaccine. They note that the primary immunogenicity endpoints were met with two 50 microgram doses in those 6 to 12 years of age. They note that the antibody titers are at least as good, if not better, than the antibody titers that were observed in adults, and similar reactogenicity and tolerability profile. They did release in a subsequent press release statement that vaccine efficacy was 100%, and we are waiting actual published data related to this. But again, similar to what has been seen in adults, very high level of efficacy after 2 doses of vaccine. CDC estimated benefits associated with implementing Pfizer vaccine. And again, you can see these numbers are somewhat similar to the adolescents in terms of prevention of severe outcomes. They have a new formulation here in the US for the 10 microgram dose to facilitate ease of administration with different color coding. And importantly, they do appear to have better stability data, supporting keeping it in the refrigerator for up to 10 weeks post removal from a deep freezer. So other companies are also working internationally to generate data. there are really not good published data about the safety, immunogenicity, and efficacy of other vaccines worldwide. But importantly, the COVAX vaccine there appear to be several trials that are ongoing up through this study here. For Covaxin also has ongoing study to evaluate safety, reactogenicity, and immunogenicity down to 2 years of age. The Russian vaccine, the Sputnik 5 vaccine, does appear to have an ongoing double-blind placebo-controlled study in adolescents. For Janssen, they have extended down as far as newborns, infants, and toddlers, which is the study appears to be ongoing. And then for the Oxford AstraZeneca vaccine, they as well are extending down to 6 years of age with their vaccine. So all this was in part summarized by an interim statement about COVID vaccination in children and adolescents from the WHO. They do note that trials as young as age 3 were completed for 2 inactivated vaccines, the Sinovac Coronavac and the BBIBP Corv vaccines. These products were approved by Chinese authorities for 3 to 17 years of age. But they've received EUL for adults, but have not received WHO EUL for children. Covaxin, developed by Bharat, was approved in India for the age indication of 12 to 17, but also has not received WHO EUL. And then they also note that India is also given approval to ZyCoV-D, a novel DNA vaccine for 12 to 17-year-olds. So the efficacy of these vaccines here, importantly, is actually 0. So it's not that vaccine save lives, but rather it's vaccinations that save lives. And importantly, there's a lot of concern about how the extent to which these will actually be implemented. And so this is a nice report from the Kaiser Family Foundation here in the US, which essentially looked at the adolescents. And if the parent had been vaccinated, then over 60% of the adolescents of those parents had received vaccine. Whereas if the parent was unvaccinated, then over 50% of the adolescents the parents said that they will definitely not get them vaccinated for COVID-19. So this does suggest vaccine hesitancy is going to be a big problem here in the US and potentially in other locations as well. Should we mandate a COVID-19 vaccine? This was an ethical evaluation of that. And in essence, they highlighted the fact that these various things needed to be effectively sorted out, many of which have been addressed, but this implementation related with the vaccine is acceptable to the medical community and the public will continue to be a big issue in a number of areas. So summary of the immunogenicity and efficacy. Clinical trials of adolescents with the mRNA vaccines demonstrate similar reactogenicity and immunologic response to adults. The Pfizer vaccine has an EUA to age 5. There's less systemic reactogenicity, similar immune responses. Moderna has a press release and is applying to EU. Other manufacturers are moving forward vaccines in children, including the following. Data are needed for the dosing, safety, and immunogenicity in children. Hopefully we'll see those move into the move forward via publication. Ultimately, vaccine hesitancy in parents is likely to impact uptake in children, and we need data supporting the importance of pediatric vaccines. So we'll conclude with the search for a vaccine continues forward, and thank you so much for your attention.
Thank you very much. Well, with this, we have finalized the first part. A fantastic context talk by Sophie. The indirect effects, tremendously important. And Evan has sort of done a state-of-the-art review of where we are and where we are not with vaccinations and pediatric vaccinations. And the idea now of this panel, of the second part, is to have a world perspective of what's really going on with vaccination with COVID-19, especially in children. That is the focus. So we will start with Hassan Tezer, Hassan is a pediatric ID specialist, chief of pediatric infectious disease at the Gazi University Department, Gazi University, and he has been in several advisory boards for the Turkish Health Ministry related with COVID and others. So thank you, Teaser, and give us a perspective of what's going on in Turkey.
Okay, thank you very much. I will summarize the latest situation in Turkey. And on March 11, 2020, the World Health Organization declared COVID-19 as a global pandemic. At the same day, the first COVID-19 case in Turkey was reported. Then a repeat increase in the number of cases was observed in April in Turkey. And today, Turkey has reported nearly 9 million cases and 75,000 deaths totally. At the beginning of the pandemic, children accounted of approximately 4% of the total cases. This low level is by interruption of face-to-face education in Turkey. After opening of schools, all levels in September 2021, children's infections contributed today around 50% of the total COVID-19 cases in Turkey. And different approaches have been implemented in Turkey to control the pandemic, terminating face-to-face learning in schools and universities, shutting down communal spaces, postponing community events, and travel prohibitions were some of the measures taken in Turkey to bring the spread of the virus under control. And in addition, isolating individuals at home and postponing routine follow-ups and elective hospital consultations were recommended. A curfew for individuals under 20 years of age and over 65 of age was commenced, but a long-term lockdown was never initiated for the general public in Turkey. And what about the vaccines in my country? All of the vaccines in the Turkish National Immunization Program are free of charge to all people living in Turkey and accessible via family health services. Mostly, family practitioners are responsible for implementing and following routine childhood vaccinations in Turkey. Due to the prevention and restriction approaches applied for controlling the spread of COVID-19 during the early period of the pandemic in Turkey, there may be some changes in physicians' and parents' attitudes regarding routine childhood vaccination services. At the beginning of the pandemic, a slight decrease was observed in national routine immunization program because of the fear of the families for going to health center. Afterwards, by the proper management of the process and appropriate family-centered arrangements, the old regular rates were returned and still routine vaccination continues as intended. I can say that each vaccine had an administration rate over 90%. I think it is important to maintain the best possible vaccine uptake to prevent a resurgence of these infections. And in Turkey, inactivated COVID-19 vaccine, name it CoronaVac, and one mRNA vaccine, Pfizer-BioNTech COVID-19 vaccine, are available currently. Firstly, CoronaVac was approved for use in people above 18 years old. And then Pfizer-BioNTech COVID-19 vaccine was approved for use in people 16 years and above. The Pfizer-BioNTech vaccine for children aged 12 to 15 years old was launched in Turkey on August 2021. To date, Pfizer-BioNTech COVID-19 vaccine is not approved for children younger than 12 years old, and CoronaVac is not approved for children under 18 years old. More than 120 million doses were applied to people 18 years old and above. As most countries strive to achieve COVID-19 herd immunity through widespread vaccination campaigns, Turkey had achieved nearly 80% vaccination rate for adults so far. There is no data announced by the Ministry of Health about the rates of COVID vaccination in children. But it is known, unfortunately, that the rates of vaccination between the age of 12 to 17 years old children are low. And COVID-19 childhood vaccination rates are trying to be improved through written and visual media and social media, aimed at informing the public and special service areas. Pediatricians in my country are encouraged to promote vaccination through ongoing proactive messaging like reminder call, vaccine appointment, vaccine clinics, and to use existing patients' visits as an opportunity to promote and provide COVID-19 vaccines. Besides, family interviews are made to inform families about the safety of COVID-19 vaccines in 12 to 17 years old age group. And lastly, I will say that still in my country, physicians are still the most trusted advisor and influencer of vaccination behavior in patients in Turkey. Thank you very much.
Thank you very much. Our next panelist is Dr. L.A. Somek, who's a professor of pediatrics at the Sackler School of Medicine at Tel Aviv University. He's the chairman of pediatrics at Mayane Hashira Medical Center and a member of the Advisory Committee for Immunizations and Infectious Diseases of the Ministry of Health of Israel. Dr. Somek.
Thank you. Thank you for the introduction and for inviting me to take part in this exciting webinar. I would like to share with you some of our clinical and research experience, emphasizing the importance of protecting children from COVID-19 infection. We've studied the dynamics of intrafamilial transmission of the virus in our region during April 2020. That quite early in the phase of the pandemic, when we observed a relatively minor role of children. The rate of infection in children aged 5 to 17 years following detection of COVID-19 case in the family was 30%. However, when we repeated the survey on January 2021, when the British variant was dominated, we observed a dramatic increase in infectivity in this age group inside the family, and 70% of them got infected following an infection of another family member. These results demonstrate a concerning phenomenon in the evolution of COVID-19 epidemiology. And every new variant is more infectious and more transmissible among children. Indeed, the share of children among positive cases in Israel increased from less than 30% in the early pandemics to more than 60% during the last month. In addition, children participate more and more in spreading of infection to the entire population, while in the first few months of the pandemic, epidemiological investigation and contact tracing in Israel revealed that only 7% of infection in adults came from young children. These rates dramatically soared to almost 50% of adult cases originate from children younger than 9 years recently. Therefore, according to the dynamics of these pandemics, it seems that almost all children will get infected sooner or later unless they are vaccinated. In Israel, COVID-19 vaccine are recommended for all children older than 5 years of age. And so far, about 60% of children aged 12 to 15 years and 80% or 10% of children 5 to 12 already got vaccinated. with at least one dose of Pfizer mRNA vaccine. Children older than 12 years are also eligible for a booster dose. And indeed, pediatricians take a major part in promoting this infection to children. We've seen relatively minor side effects in this age group, and fortunately, the rate of myocarditis were much lower than in young adults. It is also important to recognize not only the direct effect of COVID-19, but also the suffering of children during the corona. We studied the effect of isolation and lockdown, and we observed the fear, anxiety, sleep disorder, behavioral and eating disturbance associated with the stressful situation. So we now have the prospect of releasing children from these adverse occurrences, and we should not miss the opportunity. I would like to finish this part by sharing with you our clinical experience from the last few days in our pediatric wards, which is crowded with children, some of them with influenza complications, including arthritis, pneumonia, and encephalopathy. We heard this morning about a fatal case of influenza in a 6-year-old boy who was previously healthy. However, influenza vaccination rates among children and also among healthcare workers in Israel are relatively low this year. I therefore urge you not to abandon routine vaccination, and COVID-19 pandemic should not be an excuse to neglect the routine care of children. So please keep vaccinating children. Thank you very much.
Thank you very much, Eli. And we're already seeing, people are asking, we're going to show slides in this section. No, we're not going to show slides. Our panelists did have slides, but we asked them not to do so, so we'd have enough time for each one to share their insights, but without slide presentation. And we're already seeing the differences that are occurring between countries. Just the two initial talks show the difference of the vaccines that are being used in Turkey compared to Israel, and the difference in the strategy of advancing with children at this point. So we see what's going on in the world, and that was the idea of this part. So thank you very much, and it's certainly fascinating to see how this is evolving. We will move now to listen to experience in Austria with Hans-Jürgen Dornbusch, who is associate professor at the University of Graz in Austria, specialized in infectious diseases, a consultant in infectious diseases in Austria, and we're open to hear what's going on in your country.
Thank you very much for this kind introduction and for the invitation to share the picture we have in Austria, the Austrian situation with you. I just have to extend a little bit. I'm changed from the university to a different kind of working as a pediatrician, and I'm a primary care pediatrician. I have been primary care pediatrician for 15 years now already, but still connected with the university and holding lectures. Yes, we are currently witnessing the decrease of the fourth corona wave also in Austria, and ended the last lockdown last weekend, and as a specialty for vaccinated people only. So the non-vaccinated are still in lockdown, which is of course creating a lot of discussion and will be difficult to control. Just for the coverage in Austria, and that shows a little bit that Austria reflects more or less an average country in Europe. We have about 78% of adults fully vaccinated, and if you look at the whole population of eligible people for vaccination down to 5 years of age now is 67%, and this is exactly the EU average. With the population younger than 18 years of age, we reached already 18%, which is above for my, I was kind of surprised when I looked at the numbers yesterday, above the EU average, but as we heard just still much below the Israeli numbers, which are always impressive. Austria has some traditional vaccination hesitancy, and it might be interesting to see the factors that hamper vaccination rates in Austria. And one of them is the Federal Administration of National Immunization Plans. This is certainly true for other countries too, but if you see the small country of Austria with 9 million people, we have 9 provinces, and the immunization plan is put into practice in 9 individual ways. The same also occurs or applies to the current opening phase. So in each and every of the little provinces, you see a different kind of opening. Unfortunately, obviously also driven by economic factors like the winter tourism and so on. Then there's a traditional vaccination hesitancy, possibly also connected to a long history of suboptimal ID training. And a special feature is the influenza situation, where we have a coverage usually below 10%, which can't be imagined by other countries. This is enhanced by a liberal, so-called liberal political party, which attracts hesitant citizens as well as anti-vaxxers. And this is quite a problem in Austria. Which is also concerning other countries is that the hesitancy is of course driven by fake news regarding protective measures, vaccines created by a few people only who think that they possess a higher truth above scientific evidence. And the media, also a general phenomenon probably, is that they pertain to provide balanced reports by shedding equal spotlight on extreme opinions on the one hand and evidence-based scientific knowledge on the other hand. We also saw the collateral damage of the pandemic by additional large gaps in routine vaccination, particularly in school children and adolescents. And the main reasons in Austria is that the school vaccinations are done by medical officers employed by the government. And these are completely absorbed by contact tracing. So they are not available for school vaccinations. And most school doctors, which are different doctors, do not vaccinate. And another thing that is also different from other countries, that we don't have regular well child and adolescent visits above 5 years of age, which would be very valuable to have to get the children at the age when they should be vaccinated. For example, Italy is a good example in this respect, where there are no school doctors at all, but 4 times more primary care pediatricians. In the early pandemic immunization, we also saw immunization gaps in infants and preschool children, but we were privileged to be able to fill these gaps very soon, actually, and even overcame this problem. What about corona vaccination of children in Austria? We started early after EMA approval of the Pfizer vaccine end of May, and have been vaccinating since June in the age above 12 years of age. The Moderna followed a little later in August, and is meanwhile only recommended for over 30 years of age because of slightly higher myocarditis signal. And shortly after the EMA approval of the 3rd dose BNT Pfizer vaccine for children 5 to 11 years, the Austrian Ministry of Health released a general recommendation with focus on risk groups, but not prioritization of risk groups. So it's a general recommendation since end of November. And this quick recommendation was possible because of an earlier consensus between the National Pediatric Society and the Technical Advisory Group based on the available data and the FDA emergency use authorization, which had been taking place weeks before. This also connects to earlier mentions, amongst obviously other reasons. This was mainly driven by the goal to keep schools open in light of these psychosocial, social and also economic sequelae of homeschooling. We have no other vaccines for children approved or recommended in Austria, no Indian, Chinese, or Cuban vaccines. And the vaccinations are performed in pediatric offices and in vaccination hubs, mainly by pediatricians. For this younger group, we don't have much experience because we started 2-3 weeks ago. And in my office, I had the third row of 90 vaccinees yesterday, for example, and still can only from this small group, which is statistically not relevant, confirm that the tolerability is very high. It's so well tolerated. This general approach in SARS-CoV-2 vaccination of children was also suggested in a joint statement of the European Confederation of Primary Care Pediatricians and the EAP, the European Academy of Pediatrics, which was published in August. So this reflects a European approach. Let's shortly go on to the measures we took to improve vaccination rates. First, continuous information campaign and the daily efforts by the physicians are exhausted, and the non-vaccinated part of the population seems hard to reach. There was a discussion of rewards and sanctions, and finally, recently a political decision was taken for mandatory vaccination for all people above 14 years, which should start in February 2022, with the argument to transfer the responsibility for immunization from the citizen to the government. The Pediatric Society currently is discussing intensively arguments to possibly exclude adolescents below 18 years of age from this mandatory vaccination and from other motivating measures. May relate to a joint statement of the EAP, Ethics and Vaccinations Working Groups, where we emphasize the importance of communication, making immunization of children and adolescents a matter of fact. It's a dream, of course, and leaving mandatory vaccination as last measure. In conclusion, I wanted to say that vaccination, and currently versus corona and influenza, as already alluded at, together with protective measures, is currently certainly the best tool to help ending the pandemic. And from our pediatric point of view, one of the best ways to convince hesitant families is vaccination of younger children performed by primary care pediatricians, either in the office or in the vaccination hub, and communication and information received by the child's primary care pediatrician is essential. A recent survey by the European Academy of Pediatrics via pediatric offices in 18 European countries with nearly 6,000 respondents revealed that parents trust the primary care pediatrician more than any other caretaker. And clear uniform messages by all those involved and easy access to vaccinations are certainly the key factors. Thank you.
Thank you very much. Our next speaker is Dr. Eduardo Lopez, who's a renowned Colombian pediatric and infectious disease person, trained at Miami Children's Hospital and at the University of Texas. And he will be talking about in the Americas, the experience. Dr. Lopez.
Thank you. Thank you, Walter, Miguel. Thank you to the IPA for the invitation and to everyone who's connected. So yes, so I will mention data on South America, specifically in Colombia, where I'm from. First, I will quickly mention a little bit about COVID-19 cumulative data regarding the total number of cases per million people in South America, which is around 90,000. Certainly lower than in the US or in the European Union that are seeing 150,000, 110,000 cases per million people respectively, but higher than the world average, which is 34,000 per million cases. But that's cumulative data. When we see daily new confirmed COVID-19 cases per million people, we see that currently in South America, we are sort of in a honeymoon in a decreasing way since July, when cases started to decrease. Right now we're seeing approximately 44 per million people. And this is lower than the 500 per million people that are seen in Europe or 350 that are seen in the United States. So what we do have for pediatric cases, it's interesting to compare or contrast to what was recently mentioned in other talks, the fact that at least in Colombia, there has not been a significant increase in cases in children with the shifting circulating variants. Currently, Delta variant in Colombia accounts for approximately 80% of the cases, while the remaining 20% are due to the new variant. And the proportion of pediatric cases has been steady at around 11% since the beginning of the pandemic. And in the last 14 days, it's been 10.5%. So not a significant increase as has seen and presented in the past few minutes. So regarding COVID-19 vaccination, I think the first thing to mention is that there is marked heterogeneity in the region, in South America. That is between countries and within countries. Between countries, we can see the example, for example, what happens in Chile, in Uruguay, where approximately 80% of the population are vaccinated, in contrast to what is seen in countries like Bolivia or Guatemala, where between 25 and 35% of their population are vaccinated, and even more contrast what is seen in Haiti, when around 1% of the population is vaccinated. So it's a very heterogeneous situation. And specifically for children, the rollout is going at different paces. Some countries have been vaccinating for several months, while others are just beginning. For example, for first doses in Chile, I know that in children from 6 to 11 years of age, approximately 70% have been vaccinated, and Miguel can correct me if I'm wrong, but that's the official data from the National Institute of Health in Chile. And in Colombia, where we began vaccinating a couple of weeks ago, maybe 4 weeks ago, only 2.5% of the children between 3 and 11 years of age have been vaccinated. So also important to mention is that in addition to this heterogeneity between countries, even more unfortunate is the inequities within countries. This is a phenomenon that became more evident by the pandemic and is one for which children suffer greatly, as we heard from Dr. Sulfi. So what vaccines are being used in children in this region in South America? Well, first of all, to mention that several countries are vaccinating children, some from 3 years of age, others from 5 years of age. Most countries use inactivated vaccines, Sinovac or Sinopharm, especially in children under 12. And several others are also or have been authorizing recently the use of BioNTech and Pfizer vaccine. And in adolescents, several countries use the BioNTech Pfizer vaccine for adolescents. So regarding safety data, as also was mentioned by Dr. Evans before, there is not published data, not for inactivated vaccines, but there is data available, again, from the National Institutes of Health on different countries. Official documents that are publicly available, for example, the example of Chile, where currently more than 1 million doses of Sinovac have been administered, and data from the first 643,000 doses in children from 6 to 11 years of age is available. Of those 643,000 doses, 71 events supposedly attributable to vaccination, or ESAVIs, were reported. This is a passive reporting system. We all know the limitations of passive reporting systems, but it represents 0.01% of all doses. And only 4 events of 640,000 are classified as serious, which are still under investigation to assess their association with the vaccine. Argentina has another example that is important to discuss here, and is the fact that nearly 2 million doses of Sinopharm have been administered to children between 3 years and 11 years of age. And the rate of ESAVIs per 100,000 doses is low at 7.9, which represent less than 0.01% of doses. And these are not necessarily related events. So So I have information that I can share with you on the impact of COVID on routine childhood immunization and what we are doing in Colombia and in Latin America to address this. However, my 5 minutes are up, so maybe we can discuss it later in the round of questions. Thank you very much.
Fantastic, Eduardo. Thank you very much. Providing data that's not published, but very relevant in the empiric use of vaccinations in children in many countries, and in Latin America, mostly the inactivated vaccine, where safety is a key issue, and the data is very promising in terms of safety. So thank you very much for sharing. I know you have a lot more data, but we truly appreciate giving an overview of what's going on in Latin America. So once again, very interesting to see the differences that are occurring around the world. Interesting and also preoccupating at some stage. So now we move to Europe again with Dr. Catherine Well-Olivier from France. Welcome, Catherine. She's an honorary professor of pediatrics at Paris 7, and she has a vast experience. She's been head of Department of General Pediatrics. She has been a member of many advisory technical groups in vaccines, antibiotics, and antivirals. For the French Drug Agency. She has also been working in working groups for the European Center for Control and Prevention. The European CDC has over 200 publications, a very well-versed specialist to give us an overview of what's going on in France. Catherine.
So thank you very much for inviting me and your kind words. I will speak of two aspects and be very factual about the possibility to offer vaccines to children 5 to 11. So first, the background. So far in the vaccination against COVID, we have nearly 90% of people 12 plus having received their full primary series. That means 2 doses, or having been infected and proven infected, they receive only 1 dose. At the moment, 26% of those people have received the booster. If I focus on the 12-17 years old, around 3 in 4 have received their primary series, and it was quite a success, I must say. Now, on an epidemiological point of view, we are entering the 5th wave, and Omicron is arriving, as in the rest of Europe. The incidence of infection, meaning PCR or antigenic test positive, is at the moment, those last days, highest in children 5-11. It's up to 900 per 100,000, compared with the global population around 500 per 100,000. So we see that clearly the virus is focusing on those children. In children 6 to 10, since the beginning of the pandemic, we had around 400 cases of multi-inflammatory disease. And the incidence in this age group is considered to be 60 to 65 per million, compared with 44 per million in children 11-14. So it seems to be non-neglectable. Hospitalization rate in children 0 to 9 years is around 1.7 per 100,000. We also consider that around 20-25% of children have a natural immunity so far.
Encore un peu de
And the
patience.
paradox is that we have very few deaths in children and less than 100.
Mes excuses. Je
What I would
rencontre
like to
quelques
say
problèmes de
is that
connexion.
in our,
Veuillez réessayer plus
in
tard.
our policies, we consider the fact that being infected with a PCR positive allows us to drop 1 dose in the vaccination. So please note that this will also be true in children. And if I consider now what will envisage as an immunization policy in children, the main aspect is to get an individual direct benefit mostly. We want also, and it was said by previous speakers, we want to keep the school ongoing and casual activities in this age group, because we have seen the devastating aspect of closing school, not for very long in 2020, around 10 weeks, but even like that, and psychological impact. We hope, but we are not very strong on this aspect, to get an impact on the circulation of the virus. So how will we do that, and who is going to vaccinate? First, and we are starting now, the risk groups will be vaccinated. In the country, we estimate the numbers to be around 350,000 children from this age group, or children living in close contact with immunosuppressed adults. Healthy children, we envisage to start the vaccination in January 2022. And I must say that so far, we are expecting safety data on the long term from countries already vaccinating. I'm thinking of the States, I'm thinking of Israel, especially, and maybe Austria. Definitely, it will not be a mandatory vaccination, and there will be no pass sanitaire pending, contrarily to adults. We consider that if we want this strategy to succeed, we need to carefully prepare the logistics. We wonder who will be able to vaccinate. General practitioners, pediatricians, definitely, but pharmacists maybe not. And in center of vaccination that have been very useful for the vaccination in adults and very successful, maybe it will be difficult and it takes time to organize. Mostly, we want to develop trust with leaflets, education, because the last survey we did in the country showed that 2/3 of parents say they will not vaccinate their kids. So vaccination has to be a shared decision. And so we want to prepare very carefully this vaccination, considering that most probably it will be useful at least for the children. Thank you.
Thank you very much. Our last speaker of this session comes from a continent that is very important, as illustrated by Zolfi. It is Leogracius Manu. I apologize if I mispronounced that. He's a consultant pediatrician and honorary lecturer of pediatrics and child health at Makerere University in Kampala. He's a founding member of the board of the East and Central African Vaccine Institute, and over the last decade, he's dedicated his time, his commitment to immunization programs in Uganda.
Thank you, Walter, for the kind introduction, and welcome everyone to Uganda. And it's very excited to be part of this seminar and webinar. Uganda is quite unique in the sense that we have over about 40 million population, and of that, 50% are actually children. So when the pandemic started, there was a big concern that initially this was going to be a pandemic of children. But as the months went by, we found that it was actually a big challenge within the adult population. We're also unique in the sense that we have actually had the longest period of closure of schools. We're still currently in the closure of schools for children under 18 years. And I'm happy to also say that in January, we should be opening schools. So back to some statistics. As of the 13th of this month, we've had a total of about 128,000 cases of COVID, of which we've had deaths of about 3,200. So that shows you that our case fatality is quite low as 2.5%. However, it should be noted that we also have a poor uptake of vaccines within the country. Of a population that we estimate to have about 25 million people vaccinated to have a good, safe opening of the country, we have only about 8 million people who have been vaccinated. In terms of the pediatric population, we have seen very few cases of pediatric COVID, either because we're not detecting it, or because people who see the children who have COVID may not pick up this diagnosis. Recently, during the Delta wave surge in the country, we opened up in our National Referral Hospital a 20-bed higher dependency unit hoping to pick up as many children as possible. And I can tell you the unit only stayed open for about a few months and we had to close because we were getting maybe 1 or 2 patients every day, compared to the adult unit, which was getting close to about 300 patients every day. In terms of vaccination for the pediatric population, we have recently in the last few months opened up Pfizer to vaccinate children between the ages of 12 to 18 who have high risk conditions, diabetes, high blood pressure, sickle cell disease, and any other comorbidities like possible heart conditions, where we're able to at least offer that. The main aspect of vaccination is for the adult population. We also have AstraZeneca, we have Sinovac, we have Johnson & Johnson, but it's mainly Pfizer that has been approved for children. Important to note is that the impact of COVID on children has been more in the indirect effects. High numbers of teenage or adolescent pregnancies, a lot of child abuse, a reduction in the routine uptake of routine immunization. A lot of children have lost out with friends, they're not going to school, and the few who have enough resources are able to continue with online learning, but the bigger percentage are actually not receiving that. It's also important to note that as we look at the effects of school closures, we're having a dramatic effect on the general population of children. As the Uganda Pediatric Association, we have pushed forward to the reopening of schools to enable a clear effort to ensure that the children get back into school. We have seen a low incidence of COVID in our children, and I'd mentioned earlier, it may be the case of us not detecting it, but we have actually seen a low incidence of COVID in our children. Lastly, as I wind up, it's also important for us to know that children are the hidden victims of this COVID-19 vaccination, and we need to advocate and show the importance why they need to be vaccinated, not just for the routine, but for all vaccines that are required for the children. Thank you very much, and over to you, Walter.
Thank you very much, Dr. Munube. And unfortunately, we should be beginning now the questions and answer section, but we are on time and we're very respectful of your all's time. We've already been an hour and a half, which is quite unusual. So we will receive your questions, and there are many questions and answers, but I think the discussion has been extremely rich and most points have been touched in a way, and we will try to answer them by email. If I would have to summarize very quickly, I would say that we all agree that the indirect effects of COVID in childhood have been supreme, especially school closure, and that we need to advance very quickly on this. And maybe in a future pandemic, hopefully far away, we'll better think about what we need to do with our children if it has a similar epidemiological evolution. The importance of advancing vaccination in priority groups is critical, especially the adults. And we've seen large diversity of strategies in pediatric vaccination around the world, a lot of empiric vaccination. We need to learn more. We probably will need to advance in pediatric vaccination sooner than later all around the world. And hopefully countries will be able to do this as the months go by. I will pass back to you, Walt, and go ahead and see how we finalize this fantastic webinar.
Thank you very much, Miguel. And I really want to thank all of the speakers. I think it was very helpful. I think what is clear, as Miguel and others have said, is the indirect effects. But when you talk about a 100% susceptible population, even though the rate of some of the complications in children is low, on a country level, it can be substantial. For example, in the United States, according to the American Academy of Pediatrics, about 17.2% of all the cases through December 9th were in children. If you look at hospitalizations, about 27,000 hospitalizations were in children. This was only 2.7% of all hospitalizations, but still not trivial. And there were over 600 deaths a small proportion of the over 800,000 deaths we've had, but not trivial when you talk about things. So I think for two reasons, I think we need to learn more about children, and I think we need to get better data on safety and effectiveness of vaccines and overcome the hesitancy issue, which is certainly a major problem in a number of countries in the world. I think the fact that we have so many people participating here is a good thing, and the need to protect children from the indirect effects. So I think clearly the adults and getting them back to school, et cetera, but also for their own health. I think it would be helpful to have programs that target children. And then I'll turn it over to Naveen.
Thank you. Thanks, Walt and Miguel. Thanks all the speaker, Julfi and Ivan. Thanks all the panelists, because that was very rich discussion from all the regions. We have representation from all 7 regions of IPA. Thanks to all delegates, and thanks to everyone who have made this possible. You have we have posted. We will share the recording by mail with all attendees. Those who have stayed till last will also get a certificate from IPA, and we will also post on IPA YouTube channel after 24 hours. So you know, and there is always more viewer on afterwards the webinar than during the webinar, but this was the first time that we have such a record attendance, close to the 1,000 from the Zoom and YouTube. And you have received a link in the chat box. Please fill up the survey, and we will also send by the email. And thanks to everyone. Thanks to our sponsor of this program, Sanofi Pasteur. And thanks to our IPA standing committee for supporting us. And that's it. We will definitely collect all the questions, get answers from the panelists and the speaker, and we will send it, post it on some place in IPA website and share the link with you. Thank you so much. Thank you.
Thank you, Naveen. Thank you, Walter. Thank you, Miguel. Ciao.
Thank you all. Thank you so much.
Thanks to the IPA staff for staying so late in India and supporting this. Thank you so much. Okay.